Hello, everybody. We're going to talk here about something that you're going to see pretty frequently, and that is chronic kidney disease. Now, this is the feared complication or end result of a lot of renal processes. You think about diabetic nephropathy, you think of hypertensive nephropathy, you think of all the glomerulonephritides. This is the feared end result of those disorders, and it doesn't always get to this stage, but in many cases it does, and we need to know how to manage this. If you haven't had the chance yet, please consider subscribing to my Patreon. You can get there by clicking the link in the description of the video or on the I button in the upper right-hand corner. I very much appreciate all the contributions that I can get to help offset the cost of these videos, and I thank all those of you who have already donated. Definitely subscribe to my channel and you'll get notifications every time I put a new video up. Okay, so chronic kidney disease is characterized by long-term permanent decline in renal function as measured by the glomerular filtration rate. So this is different from acute kidney injury or acute renal failure, which is reversible. It goes away when we address the underlying cause, whether it be giving fluids for pre-renal failure, whether it be giving corticosteroids or cyclophosphamide for a glomerulonephropathy, or whether it be relieving an obstruction for a post-renal failure. This cannot be fixed. So it's a permanent decline. Now, we can slow it, but we cannot, or we can even stop it, but we can't fix it. There are many causes of chronic kidney disease. The most common in the United States is diabetes, diabetic nephropathy. Another common cause is hypertension, so diabetes and hypertension, and together the two of them make up about 2/3 of all cases of chronic kidney disease. Then we have other things like inherited polycystic kidney disease, amyloidosis, and the various glomerulonephropathies, which I talked about in a previous section. It does affect 1 in 7 U.S. adults, so that's very, very common. That's just a little bit less common than breast cancer. So this is a very, very common disorder. 37 million Americans are affected. Typically, this is identified through routine screening. What we have is a patient who's got risk factors, long-standing hypertension, long-standing diabetes, and we get a BMP and we see their creatinine level is high. That will then be repeated, and it continues to be high, and then we diagnose them with chronic kidney disease, which we have in five stages, which I will point out to you in a little bit. There is a higher incidence in blacks than in whites, and we don't really know why. However, we do know that there is a mutation, a polymorphism on, I believe it's one of the channels, don't quote me, that sub-Saharan Africans tend to have that others do not. So that may predispose them. However, there are others that believe that it may be due to healthcare access disparities. Obviously, if you can't get your metformin or whatever you need to keep your A1C down and to keep your blood sugar under control, that's going to raise your risk if you have diabetes. Same for blood pressure. So certainly access disparities does play a role, but there may be a genetic predisposition. End-stage renal disease is the final stage of chronic kidney disease. We try to avoid this. You can have chronic kidney disease and not be an end-stage renal disease where you would need either a transplant or long-term dialysis. This is just my references from the previous slide. Okay, so like I said, these are the causes. Diabetes and high blood pressure make up almost 2/3 of all cases. Now, this would be your initial workup, and I would actually do this every year in a patient who is coming in, well, not all of these, but for a long-standing diabetes or long-standing hypertension patient, especially if they're not well controlled, at the very least, I would get a BMP and a urinalysis. But if they start showing signs of chronic kidney disease, of uremia, then we may need to go a little bit more in depth. And these patients, of course, should be referred to a nephrologist. These are some of the things that they would do. So you want to get all your electrolytes, BMP, serum calcium, serum magnesium. Those are not included on your BMP. CBC can be useful. Urinalysis, we're going to see, can be really useful. You want to make sure you're getting urine albumin and urine creatinine. A 24-hour urine sample can be useful, and a renal ultrasound may be good too. Further workup, you should include a lipid panel. People with chronic kidney disease are at risk for lipid abnormalities. And then other tests as needed based on the potential cause, like an A1C if they're diabetic. Now, you can use this nice formula, and it is called the albumin-creatinine ratio in the urine. You don't need to know this for your exam, but it is used by nephrologists in the clinic. Okay, now this is something you should know, and this is how we classify chronic kidney disease. It is based on the glomerular filtration rate, and we have various stages. So stage 1 would be normal. That's going to be somebody with symptoms, possibly, but their GFR is above 90. Okay, we really don't see a whole lot of that just because these patients have general good function. But, if there is proteinuria and stuff like that, we may classify it as stage 1. Stage 2 is 60 to 89. Stage 3 is 30 to 59. This can be broken up into 3A and 3B. Stage 4 is 15 to 29, and stage 5 is less than 15. That is, by definition, end-stage renal disease. Now, this is a useful graph, and what you can do is you can take the GFR on the left side here on the horizontal axis, and then on the vertical axis you can take that ratio that we talked about. Now, what you can look at here is the prognosis of progression to end-stage renal disease. So obviously, if they're G1 or G2 and they're not peeing out a lot of protein, then they've got a pretty good prognosis. However, one of the things I want you to know, and this is just good to know in general for the wards, is that if a patient progresses beyond stage 3, if they're stage 4, for instance, it's almost certain that they're going to progress to end-stage renal disease. Okay, so we can keep a lot of patients at stage 3 or better, but once they progress to stage 4, it's not good news. Now, when do we dialyze? You probably know this mnemonic, AEIOU. Whether we dialyze or not is going to depend on the patient's symptoms, not their GFR. Now, if their GFR is 13, they're going to have symptoms. But we base it on the patient's symptoms, not on the GFR. So if they have acidemia, metabolic acidosis, especially if they're stage 4 or 5, then we want to dialyze them. If they're earlier than that, you just give oral bicarb. E for electrolyte abnormalities. Usually what we're looking at here is hyperkalemia. If they have EKG changes, this is an emergency. They need to go for dialysis. I for intoxication. This is typically not people with chronic kidney disease, but think of intoxication with salicylates like aspirin, lithium, isopropanol, methanol, and ethylene glycol. I talk about these 3 in another video. O for overload of fluid, unresponsive to diuretics, and U for uremic symptoms. There is a lot. Pericarditis, pleuritis, encephalopathy or altered mental status, peripheral neuropathy, severe bleeding, diathesis, especially GI. We'll get into why that happens. Okay, so here on this slide, I organized the various symptoms of chronic kidney disease via the various functions that the kidney has. So number 1, the kidney has a responsibility to get rid of uremic toxins. And so if you don't do that, those toxins can affect the ability of various cells within the body, especially blood cells, to function properly. So platelets and white blood cells, for instance. Number 2, the kidney has a responsibility for fluid and electrolyte homeostasis and hormone regulation. So you can see a number of electrolyte and fluid issues from sodium and water retention causing hypertension and edema to impaired potassium excretion, which will lead to hyperkalemia, to impaired acid excretion, which will lead to a metabolic acidosis. And then there are also some hormonal issues with the kidney. Remember that the kidney is responsible for making erythropoietin, which stimulates the production of red blood cells, and then also responsible for the final step in the synthesis of the bioactive form of vitamin D, calcitriol. And so you can get a secondary hyperparathyroidism or osteodystrophy, and we will go into this in the next slide. And then finally, with chronic kidney disease, you often will have a progressive systemic inflammation. And anytime you have systemic inflammation, it can affect your vascular health, and it can also lead to anemia of chronic disease, which is problematic because we already can get an anemia from chronic kidney disease because of the reduction in erythropoietin. Okay, so here is a diagram, and I know this looks like a lot, but don't worry, we're going to walk through all of this, and by the time we're done, you'll have an understanding of this whole sort of thought map. Okay, so hypocalcemia and hyperphosphatemia. Why does this happen? Well, remember that the kidneys are responsible for making bioactive vitamin D, also known as calcitriol. It's an enzymatic process. It's just one step, and it involves an enzyme called 1-alpha hydroxylase. So what we're doing is we're converting 25-hydroxyvitamin D, which comes from the liver, to 1,25-dihydroxyvitamin D, or calcitriol. So what does calcitriol do? Calcitriol increases absorption of both calcium and phosphate from the gut. And this is ultimately the problem that we have, is that we are unable to absorb that dietary calcium. So if you don't have that, then you're going to have a low calcium, and you'll actually also have a high phosphate. And that's because the kidneys are holding on to the phosphate. So that's why we get that hypocalcemia and hyperphosphatemia. So what happens then? You have low calcium, you get this hypocalcemia, the parathyroids are going to sense it, and they're going to release PTH. What does PTH do? PTH does two things. Number one, it helps the production of calcitriol. However, that requires a healthy kidney. Number two, it increases bone reabsorption, and that is a place where we can get calcium. The bones are calcium stores. However, we get bone demineralization, and that is this disorder called the mineral bone disease of chronic kidney disease, so CKD-MBD. And this is an osteodystrophy. So this is something that we see in kidney disease is weaker bones. The treatment here, we need to do two things. We need to reduce the serum phosphate level. We do that by giving phosphate binders. Remember, phosphates are found in protein, and so they're quite prevalent in our diet. So you can give sevelamer or lanthanum or calcium carbonate. And then, of course, we need to treat the hypocalcemia, and we do that by just supplementing the vitamin that's deficient. We just give calcitriol. All right, now anemia is due to a reduced production of erythropoietin, and that stimulates the production of red blood cells in the marrow. This is very simple. You get a normocytic anemia. This is universal in patients with end-stage renal disease, but you just need to keep an eye on this on patients with chronic kidney disease. That's why we get that CBC. We're looking for an anemia. Now, if you have a patient with anemia, you do want to rule out nutritional deficiencies like vitamin B12 and folate. That's usually going to cause a macrocytic anemia, but just keep an eye on it anyway. Same with iron. That's usually going to cause a microcytic anemia. We just want to rule those things out. So get an iron panel, check your vitamins. But most of the time, if you have a patient with chronic kidney disease, this is going to be the cause of their anemia. The treatment here is fairly simple. We replace erythropoietin. We have an artificial erythropoietin. It's called epoetin alpha. There's another one called darbepoetin. And they basically do the same thing, but darbepoetin has less frequent dosing. So some patients will find that to be more convenient. This is indicated when the hemoglobin drops below 10. The target is 10 to 11, so we don't want to give too much. Electrolyte abnormalities we kind of talked about. these electrolytes, potassium, protons, magnesium, they all need to be excreted. We take in way more than we need. And so the kidney's job is to get rid of the excess. So if we're unable to get rid of potassium, we get a hyperkalemia. Any hyperkalemia with renal disease, you need to get an EKG because we want to check for cardiac arrhythmia. If they have EKG changes, i.e. peaked T waves, then they need to go to dialysis. Acidosis, that would be, of course, a metabolic acidosis. If they're stage 1 to 4, you can give calcium carbonate. That will alkalinize the blood. If they're stage 5, you need to give dialysis. And then and I should add also, if they don't respond to the calcium carbonate, then we would go to dialysis as well. And hypermagnesemia is fairly asymptomatic. At very, very high levels, above 12, you can get muscle weakness and apnea and bradycardia, but that's pretty uncommon to get to that. So we do just advise a low magnesium diet, and you would set these patients up with a dietitian. Okay, so this is the peak T waves. So generally, when we're looking at an EKG in a patient with hyperkalemia, we're going to look at these T waves. And on the chest leads, V1 through V6, you don't want to be more than 2 big boxes, okay? So you can see right here, we're about 2.5, and here we're almost 3. So that would be considered a peaked T wave, and that is consistent with hyperkalemia. And this is a patient that we would want to dialyze because they are at high risk of a severe dysrhythmia that can be fatal. So you see it again here. Okay, fluid overload would be due to an inability to create urine. All that fluid is going to stick around in the blood, and you will get hypertension and edema. You will have a hyponatremia because of the retained fluid, and that's going to cause edema. You can try diuretics in patients with mild to moderate renal dysfunction, so stage 1 to 3. If they're stage 4 or 5, you probably go with dialysis, same as if you had a patient that you tried diuretics and they did not respond. So that's pretty much it with fluid overload. Diuretics first if they got mild or moderate disease. If that doesn't work, or if they've got more advanced renal disease, then you will go for dialysis. Uremia is a buildup of nitrogenous waste in the blood. Azotemia is when it becomes is when you have elevated BUN creatinine. Another word for this is uremia, but one of them is kind of a lab definition. The other one is a clinical definition. So you can have pericarditis, encephalitis, bleeding, increased risk of infection. That's because it can affect degranulation of platelets. You don't need to understand the pathophysiology there, but you should be familiar with the symptoms of clinical uremia. The treatment here, if they are symptomatic, is going to be dialysis. For minor bleeding, you can give DDAVP. Remember, that helps with platelet degranulation. Infection is the number 2 cause of death in patients with end-stage renal disease. So this is really, really, really important. Okay, this is called Uremic Frost. This is interesting. So you might look at this and think dandruff, but this is Uremic Frost. This is really difficult to happen because you actually need a BUN level of at least 200. What's the normal BUN level? It's like 6 to 25 or so. So you need to really have some severe renal failure to get this. But keep an eye out for this. What happens is the nitrogenous waste products get into the sweat, and then they leave they come out the sweat glands. And then as the sweat evaporates, it leaves these essentially BUN crystals. And it kind of looks like dandruff, but you'll see it wherever you sweat. Long-term management, stage 1 to 3, we go with an ACE inhibitor, that's renal protective. We go with an SGLT2 inhibitor, that's also renal protective and cardioprotective, and this is independent of their diabetes status. We also go with a statin just because of the increased risk of coronary and peripheral artery disease, and then manage the underlying cause such as diabetes or hypertension. If they're stage 4, you go with all of these, but the SGLT2 inhibitor is contraindicated. And then stage 5 is going to be dialysis or renal transplant. Other things, hyperphosphatemia, you can use phosphate binders, secondary hyperparathyroidism, calcitriol and sincalcet. Anemia, we go with those EPO agents. Stage 3 to 5, very important dietary modification. And then all these patients should be referred to nephrology. And then this is, again, who we dialyze. Finally, renal transplant. Renal transplant gives you the best shot of long-term survival. Survival is better with transplant compared to long-term dialysis. However, of course, one of the drawbacks, unless you have an identical twin, is that you need to go on anti-rejection medications when you have a transplanted organ. The best drug for this is tacrolimus. It is very effective, and it is certainly implicated in the improved survival with time in transplant patients. And this is just a diagram of everything we went over. It's the same diagram you saw initially. So if you've followed up to here, very good work.